school, for instance. I'm sure many of you do as well, working from home, schooling from home, activities that we're used to being discontinued, places that we go not being open. That's affected all of us. But it's important, and I'm sure we all do remember that individuals who suffer from psychiatric or mental health issues or substance use disorders are going to be particularly affected by any kind of external stress or anxiety or uncertainty. Those are huge triggers, and add to that isolation and distancing from other social supports. And those are known in historical recipes for bad outcomes for individuals, either with active use, early recovery, or even long-term, seemingly stable recovery. Those kinds of stressors can really have a significant impact. The social support is just so important for so many people in recovery, not just formalized, whether it be AA, NA kinds of meetings, group therapy, or just friends and family that they're able to interact with. And losing that potential is really a huge blow to our patients. And then for those who are using, whether it's opioids or any other substance, if they're using in isolation, I have some data to talk about what some of that impact may be, but that raises the risk of bad outcomes and potentially overdose deaths because people just aren't necessarily identified or found in earlier stages as we might expect, or have other concerned individuals seek help for them, even if they aren't necessarily in extremis, but just as they're deteriorating. Ability to adhere to distancing and sanitizing procedures, whether it's from going out to obtain whatever substance of choice, or because of intoxication, not sort of adhering to masking, hand washing, distancing, any of those kinds of things. Incarceration, we've certainly seen outbreaks among incarcerated individuals and those who work at those facilities. And we know that individuals with substance use disorders, either because of their use and personal possession, and certainly for selling and other related crimes, there's a high risk and rate of incarceration. Housing instability in general, and then therefore the need for congregate housing and shelters and so forth, either in shelters increasing the risk of exposure or increasing risk of use, or the lack of housing and living on the streets. Those are all things that are exacerbated during the pandemic. Stigma is an ever-present part of what we're having to battle constantly in our care for patients with substance use disorders, and they're more aware than anyone of the stigma that exists. And that's, again, only further accentuated at a time when people are struggling themselves and potentially have more compassion fatigue. And then just existing inequities that have always been there: race, gender, geography, socioeconomic status. All of those things are just going to be increased and accelerated by a pandemic. And then sort of logistical factors like drug supply, impurity, and adulterants. We've seen some variation in fentanyl and fentanyl supplies, adulterants, mixing of drugs, people purchasing one type of drug they thought was another. And that's always happened. But again, when you think of a supply chain, so to speak, during a pandemic, those things have the potential to be interrupted or changed and altered. So as much as we have seen a rise in fentanyl over the last half a decade, locally anyway, here we've seen an acceleration of fentanyl and fentanyl-related products and some other adulterants that we hadn't typically seen, as well as unusual reactions and behaviors potentially related to things like synthetic cannabinoids that are difficult to identify. And that will continue to vary and change in the normal course of things, but certainly as the typical distribution cartels and organizations, as well as online dark web kind of sources, battle with sourcing and supplying to people who are looking for it. So some of the data, this was from June of this year in an MMWR, looking at some of the impact on anxiety and depression, trauma and stressor-related disorders, considerations of suicide, started or increased in substance use. These are pretty big numbers, anywhere from 10% to a third of people sort of relating to the one or more of these factors. And I don't think it's terribly surprising, but just sort of proves what we might anticipate. And this is by self-report, so of course, it may not be an exact representation of what's actually happening in people's minds. In addition to the mental health implications, there are the medical implications. Individuals with substance use disorders are more likely to have some degree of immune suppression. COVID itself is the impact on substance use outcomes. So whether it be underlying lung injury or infectious symptoms combined with substance use, whether sedative or opioid, that reduces your breathing or response or increases the risk of aspiration events, or again, distancing measures or general illness, not responding to the illness and seeking help early enough and waiting until there's potential for worse outcomes. The X-ray is just a kind of a typical multifocal pneumonia picture that we see in our COVID patients, that we may also see with folks with aspiration or overdose as well. Pulmonary edema can impact. We know that COVID is related with a variety of secondary effects like blood clotting events and vascular pathology and lack of blood flow to areas. Those kinds of things can be accelerated by stimulant use as well, cocaine, methamphetamine, with constriction of blood vessels, as well as an increased risk of clotting. So a variety of ways that the two syndromes can overlap and complicate one another. And then again, the risk of overdose events in isolation. So Nora Volkov and Wang and others looked at this. This was published, I think, in September, where they looked at outcomes, COVID-related outcomes and diagnoses for patients with various types of substance use disorders. And you can see that dotted hashed line, vertical line on the left, that is baseline, so all comers. And these dots with the confidence intervals represent the risk association with a diagnosis of COVID. And you can see it's anywhere from 5.5 to more than 10 times the risk of patients having a COVID diagnosis if they have a substance use disorder. So they're more likely to be diagnosed. And they also found that their death rate, their mortality with any SUD and or recent SUD was much higher than a baseline population or population without substance use disorders. And unfortunately, as is often the case, higher in an African-American population than a Caucasian population in their data source. So increased risk of getting COVID or dying from COVID among patients with substance use disorders. Then looking at overdose data, this is actually published in the Washington Post, but I thought it was a good graphic using data from ODMAP, looking at the overdose percentages and rates through the pandemic. I think one thing that's interesting is in February, of course, there's a lot of discussion about it, a lot of varying sources of information, kind of giving different information, but we were already starting to see an increase in overdoses. And what I'll show you in some subsequent slides, the end of 2019 and the beginning of 2020, we were already beginning to see a bit of a rise in overdose and overdose deaths. But it really accelerated during April and May, which were the times of shutdown and increased isolation, with up to 40% increase in May compared to 2019. This is in Pennsylvania, so this is data from the Department of Health showing that any drug overdose death, we saw more than 10% increase in the first half of this year compared to the first half of last year. Again, this is always going to be multifactorial, but it's clear that the largest impact on 2020, certainly going back to March, has been COVID and the response to it, and even prior to March. So presumably that played a big factor in a fairly significant increase in the state where I live in practice. And then nationally, we're looking, and again, this was data as of the beginning of November. So, overdose death data is always lags behind, as we know, to get final reports. But this was according to the CDC. So we can start to see this line was already sort of having an inflection point kind of in mid 2019 for the US and starting to rise through the beginning of 2020. So, I think many of us had hoped that late 2017 and into 2018 was going to be the right kind of inflection point. Unfortunately, we were already starting to see moving the wrong direction, and certainly COVID is going to be a gasoline on that fire. This data was published just a little over a week ago, or maybe 2 weeks ago now, on the 3rd of December, and this looked at EMS data. And I'll orient you to both of the graphs because I know there's kind of a lot going on and a lot of words here. But what they were doing was looking at overdose events for EMS and how many of those overdose related events were cardiac arrest. So essentially the patient was dead or dying when EMS arrived relative to responding to an overdose where naloxone was needed, but maybe not quite as serious. And so the top graph, the sort of squiggly lines that overlap one another, those are 2018 and 2019. These are the overdose-related EMS responses that were cardiac arrests. So in their incidence per 100,000 EMS calls. And so you can see they're pretty consistent. And even the beginning of this year, in January and February, maybe a bit higher, but overlapping, within error. And then this dotted line in March, so when our various shutdowns and mitigation measures began, we see this abrupt rise in the number of incidents of overdose-related cardiac arrest per 100,000 EMS calls. And that is probably a combination of factors. Overall, EMS calls declined as people were uncertain about seeking medical care and not wanting to go and potentially be exposed if they didn't need to. We saw that across emergency departments and all sorts of other acute unscheduled care declined significantly. Around here, our ED volumes dropped by about a half on average across our various sites. So part of it is that the denominator dropped, but at the same time, we look at this next graph. This yellow line are overdose cardiac arrests, and the blue line is overdose incidence, and this is percent change compared to prior. So what it shows is that the overdose incidence didn't actually change all that much as a percentage of calls. But at the same time, and this is cell phone data, this bottom line, showing mobility. So we saw a more than 50% decline in mobility, essentially increased isolation. Tracking along with that, the relative percentage of the calls for overdoses that were for overdose cardiac arrest, or essentially deaths or near deaths, or a marker likely of overdose deaths, rose quite precipitously and stayed up even as sort of we returned to more normal as far as EMS activations and ED volumes and things like that. So I think this is an early indicator of data that is yet to come for final overdose deaths, but it is certainly frightening. And I think it's a combination of decreased denominator, people not calling for overdose events that maybe they treated at the bedside with their own Narcan and didn't want to risk exposure by going to a hospital, as well as individuals sort of being sicker when they're found or closer to death because they were using an isolation. I think it's likely a combination of all of those factors. And this is just some data from our emergency departments, and this is from a couple dozen emergency departments in our system, and looking at our naloxone kit utilization and our buprenorphine induction utilization. So we saw through sort of the second quarter of 2020, where, as I said, our ED volumes overall dropped by about 50%, that our Narcan distribution, so all of our EDs have the ability to give out Narcan nasal spray kits for free to patients, so they just walk out the door with the kit. Going back to 2017, as you can see, we've had a steady rise in the utilization. We didn't really see any change in the number that we gave out in the second quarter of 2020. which is interesting. So these are patients at risk for overdose. But we did see a significant decline in that second quarter with, fortunately, some recovery to baseline of our buprenorphine inductions. And so that likely is indicative of more patients or fewer patients who are appropriate or ready for addiction care or desiring to be started on addiction care with referral. So I think we're missing opportunities where we know people were overdosing and EMS was involved, but we were less likely to be able to get them started in the emergency department. So obviously we want to see those numbers rise. And this does not account for patients who only received a buprenorphine prescription, which we've seen more and more of as we've gotten more of our ED providers ex-waiver to prescribe. So I'm going to take a break there because it's a lot of data. I know it's kind of heavy, a lot of graphs and et cetera, to see if there are questions or I can certainly continue and we can wait until the end. It's maybe not quite halfway, but a good stopping point.
Yeah, we don't have anything that's come in yet, so if you want to keep rolling, I think we'll probably have some stuff come through.
Okay, no problem. And I know that's a lot, and if I went too fast, I apologize. I try not to labor too much on the stats, but I think it's all very important. So if after the fact you want to go back and review any of those numbers or data, please let me know. So what has emerged as really an important response, as we know people are more likely to be isolated, to be in their homes, our care facilities, whether it be hospital-based or office-based, have their own restrictions, their own concerns about exposure and delivering care. We have to think about all of our providers, physicians, nurses, techs, social workers, case managers, secretaries, receptionists, everyone who's involved with patient-facing interactions, has some degree of risk. And we know that a population with substance use disorder has a higher risk of being diagnosed or developing a COVID infection. So as a result of that, in March, April, May, and again more recently, a lot of providers moved to telehealth. And for a short time, things were just closed and shut down, which was a very dangerous situation. But we sort of had to move to telehealth as a solution, both for our patients' comfort, for patient safety, and for provider safety, as well as to comply with various mitigation rules, which varied state by state. So while we do that, obviously we want to go back and take a look and say, okay, well, if we're doing this, what is our understanding of the benefit or the effect? Is this something we should be doing? Is this reasonable to provide care in this way to our patients? Are we harming them, et cetera? Because outside of typical psychiatric care, telehealth utilization has historically been quite low throughout pretty much most specialties and fields of medicine and most providers outside of stroke care and some fundamental psychiatry care. At least I know in Pennsylvania, adolescent and child psychiatry in particular was being offered through telehealth prior to the pandemic. So psychiatry does provide some historical data from going back to 2014, 2015, with a variety of studies looking at access to care and patient satisfaction and outcomes, et cetera. I will say most existing telehealth data is somewhat limited. I think there's a number of domains where we like to see data, which is outcomes. So do patients do as well as are they likely to use it, and do they feel satisfied that they're using it well? And are there areas where telehealth maybe falls short? And there's huge expansion now with devices and home monitoring and things like that to try to bridge some of those gaps. But the data that we had going back half a decade or so showed that it had good outcomes with relation to increasing access to care and improving capacity for patients to stay local, to be treated without having to travel to places where maybe there was more specialized care from either rural or low-income communities. And those are the kinds of things, the benefits that we'd be looking for now. High level of patient satisfaction, so that's key. If patients are unhappy or feel like they're not receiving good care, you may get them once, but they may not come back. which is obviously not good or a benefit. And the data that we did have showed that it was effective, that the outcomes were good and similar to traditional care. And so that was really important for saying that this would be something we could do. Sorry, declining a phone call. Thinking about some of the behavioral health care, particularly that's incredibly important for substance use disorder treatment with group therapy, et cetera, there's very little existing or pre-pandemic data. There was a systematic review that looked at the various smaller studies that have been done to try to come up with a summation of the data. And what they found was that it was feasible, that you could do group through telehealth. The treatment outcomes for those who participated were similar as in-person groups. They did see small reported decreases in therapeutic alliance, and I can say that in talking to a lot of patients over the last year, when they've had to move towards group, either AA, NA, peer-based therapy or group therapy, some have been fine with it and happy with it. Some have really not liked it and not felt comfortable with it. And I think that may not be terribly surprising. Other people prefer it. They feel more comfortable in their home. They feel a little bit more anonymity that helps them feel like they can open up more. So as with almost anything where you're dealing with groups of people, interventions can work well for some and not so well for others. And I think this is no different, but it at least is a viable and reasonable option. Medication treatment for opioid use disorder, and obviously I'm sure many of us are very familiar with a lot of the data. We've historically done whole hour discussions on medication treatment, but just as a brief summary, we know that medication treatment for opioid use disorder specifically is critical to treatment outcomes, is far superior than behavioral therapy alone when looking at relapse rates and mortality, as well as reductions in HIV, hepatitis C, reductions in crime, improvement in social functioning, the medical treatment of the essentially the neurobiological response to opioid use and addiction, as well as reductions in healthcare costs. And the degree to which it reduces costs is variable depending on the methodology and the patient subsets that are evaluated. But overall, I think it's become clear over time, and as summarized by the National Academy of Medicine in their report titled Medications for OUD Save Lives, that we know that medication-based treatment strategies are the mainstay for opioid use disorder care, certainly in combination with behavioral interventions. But as the National Academy concluded, based on a preponderance of data, medication therapy should not be withheld in the absence of behavioral interventions, though certainly the combination continues to be the ideal therapy. But access to evidence-based medication treatment has historically been limited, and this is even before the pandemic. Studies showing that fewer than 40% of patients with opioid use disorder actually receive medication treatment. A large number of counties in the U.S. don't have an X-waiver provider, and that's as of 2018. 56% of counties most in need based on diagnoses and patient population that requires or would benefit from medication therapy compared to the available providers. There's a significant mismatch essentially nationwide. And what we also know is that those providers who can deliver that care, most are not prescribing to their limit. So the average is fewer than 50% of whatever their prescribing limit is. So there's a mismatch of patients who would benefit from medication therapy for opioid use disorder, providers who can give that care, and where they are, and getting those patients and those providers to meet, essentially. And at least part of that is geographical. And I think there are other factors, some providers willing only to care for their sort of legacy or traditional primary care patients, but not looking to take on new patients specifically for treatment of OUD, concerns with DEA and enforcement, and patients maybe not wanting to seek care, a lot of stigma still around medication treatment. So there's a lot of reasons beyond just that mismatch, but that's at least part of it. So that has, prior to the pandemic, among many of us, raised the issue of, well, could telehealth serve as a solution for medication treatment of opioid use disorder? And so a couple of studies that were done, and these were published in 2018 and 2017, so obviously pre-pandemic, looking at cohorts of patients. One, the West Virginia study that compared directly cohorts of telehealth versus face-to-face, and the Maryland study looking at a cohort of patients in telehealth and comparing to historical controls and typical retention rates. Essentially what they both found were similar results: 90-day and 3-month retention rates, a little over 50%. Drug screening positivity or negativity rates, I should say, of 86% in the Maryland group. But basically finding retention rates and satisfaction rates, et cetera, similar in the telehealth groups compared to either historical controls or matched controls in the West Virginia study. So, it's at least data to suggest, and these are only 2 studies, they're not enormous, but at least suggest that there is likely a non-inferiority of telehealth treatment in a short term over a several-month period of time relative to face-to-face. So while it doesn't answer the question, can this, I don't think anybody thinks this would replace face-to-face treatment, but at the same time, I think it begins to help answer the question of whether telehealth can serve as an access point for patients who don't otherwise have the ability to see a provider for medication treatment. And of course, this is only buprenorphine because that can be prescribed as opposed to methadone, which cannot. So this was looking at buprenorphine therapy specifically. The VA actually developed a manual for prescribing MOUD at their outpatient clinics using telehealth. And they used a model, and this was just published this year. And so they have a whole manual. It is really focused on the VA, but I think a lot of their findings and recommendations can be more generally applied. But they had a process where patients were treated sort of at a hub, for addiction care, started on medication treatment and then returned to more rural or remote settings where they saw local providers, and the ongoing addiction medication treatment was provided in conjunction with their local provider through telehealth from the originating hub. And I think that is a mechanism that was, has been legal under Ryan Haight rules, which I'll talk more about, pre-pandemic, and I think offers a lot of potential for meeting patients where they are and where they're comfortable, but providing that specialized care through telehealth. So I mentioned Ryan Haight, and maybe some or many of you are familiar with this. It's often referenced when we begin talking about telemedicine or telehealth management of substance use disorders, particularly prescribing of controlled substances. So I use buprenorphine, but really this would apply to, say, benzodiazepines for alcohol withdrawal, et cetera. And what the Ryan Haight Act required was that the initial assessment, the initial evaluation by the prescriber took place in person. After that, any subsequent evaluations could be done by phone, by audio-visual telehealth. It really just required that initial inpatient or in-person evaluation. And understandably, this was responding to concerns about, as just general online access and internet-based companies were expanding. This was also at the, as we were approaching the pinnacle of the prescription opioid epidemic and rises in opioid prescribing. They're trying to avert, sort of online, ethically dubious kinds of companies from starting up and just sort of passing prescriptions without ever meeting people and not really providing appropriate care. So it had, as many laws do, good and appropriate intention. They did allow for a couple of exceptions to that in-person initial assessment, which have been important for us prior to the pandemic, and I think will continue to be. And essentially what that is if a patient is in a DEA registered facility, so if the facility is licensed by the DEA or registered, or, so it doesn't have to be both, but or that individual is in the presence of a DEA registered practitioner, then, and while you do your telehealth visit, then you may prescribe them controlled substances, including buprenorphine or benzodiazepines, after the telehealth visit only, without your own personal in-person evaluation. As long as a telemedicine provider is, licensed and practicing within their usual course of clinical practice, is within their buprenorphine prescribing limits and all those other factors, typical regulations. And this has been permitted since 2008, so there's not been prevention of that. And more recently, in 2018, the Support Act, which again, I'm sure many of us are familiar with, had many parts that affected a variety of our efforts to combat substance use, but specifically opioid use disorder. In there, recognizing the growth of telemedicine, the potential to improve access to care, it did direct the Attorney General in consultation with the Secretary of Health and Human Services to create and issue final regulations to allow special registration for telemedicine delivery of addiction care. And the hope was that this was going to allow for an increased ability to provide telemedicine care. Unfortunately, this has yet to be done, despite being passed into law more than 2 years ago. I think it's fair to say there's been a lot going on in DC that has likely distracted both the Attorney General and the Secretary of Health and Human Services. But unfortunately, so fortunately, there is legislation there that could permit some further direction, but it has yet to be acted on. So how can we apply those existing regulations from the Ryan-Haight Act to telemedicine care? And this, I have buprenorphine, but again, we have used these regulations to deliver benzodiazepine therapy for patients in alcohol withdrawal, for instance, with patient or providers who maybe weren't comfortable with it. So if that patient is in a DEA registered facility or an office, so even if there is not a DEA registered provider there, if there is the capability of providing or doing a telemedicine visit, I, for instance, from a remote location, can do that visit evaluation and prescribe the medication. Or say in a primary care office where maybe the facility is not DEA registered, but the primary care, whether it's a physician or nurse practitioner, has a DEA license, but in the case of buprenorphine is not X-waivered or isn't comfortable prescribing buprenorphine or benzodiazepines for alcohol withdrawal, et cetera, they would be able to consult me through a telehealth visit in their presence, and then I would be able to prescribe the medications. And same could be done in hospitals, emergency departments, urgent cares, any other type of facility or that's DEA registered location where there is a provider. We've actually been doing this service here at some of our hospital emergency departments for several years, where we'll do a video telemedicine visit while patients are there in order to prescribe buprenorphine in appropriate patients to facilitate their follow-up with addiction care, that may be 3, 4, 5 days away. So what are some of the barriers to delivering that care? One is workforce availability. So again, pre-pandemic, very few healthcare providers of any specialty were using telehealth with any regularity. Maybe occasionally, maybe some physician-to-physician interprofessional consultation, but rarely direct-to-patient audiovisual telehealth. There were some applications and some services and some providers who were working it in more than others, but the vast majority were not. And then patients, being familiar with and able to access it, that requires that they have equipment. Either a facility or the patient or the provider who's willing to do the telehealth has to have appropriate equipment and applications that meet privacy requirements. And patients have to have broadband access or, an iPhone or iPad or some other internet capable device in order to do an audio-visual telehealth visit, which is what was required previously to do these. And so we know a bunch of people don't have those accesses or those technologies. Registering and documenting a patient. So if I'm willing to see patients at, say, their primary care doctor's office, but I don't chart on their system and that patient isn't registered in my system, how do we bridge that gap? You know, we have to learn all of the EHRs, all the practices where we could provide the service, or have a cumbersome additional registration process so that I'm able to document in order to create a medical legal document record of my visit and my medical decision making. So while it seems simple, that is a bit of a barrier. Patient provider acceptance we've talked about, and reimbursement. Reimbursement has been highly variable nationwide. More and more states are passing laws and regulations to require reimbursement, as you can see here. All those states in gray, this is as of earlier this year, have some law on the books that requires some type of reimbursement of telehealth. And it can look different in different states, as so many healthcare related laws. But you can see those sort of tan colored, including Pennsylvania, where I work and practice, that don't have those laws. Medicaid has permitted it, but that's been somewhat limited and somewhat nebulous. A lot of MCOs and certainly private insurers have not historically reimbursed for telehealth. They have during the pandemic, but if that's going to continue and at what rates, whether there's parity, as there are in 6 of these states, where the professional fees are essentially equal for in-person as well as telehealth care. All of those things will impact how well we're able to implement this moving forward. And so I think it's important that we have ongoing advocacy. And while parity seems as though it may be too much, you can say, well, you don't have to pay rent and those things. But practices still have to have offices, and it doesn't, I can tell you a telehealth visit does not take less time than an in-person. In fact, it probably takes more. There may be more liability associated with it from not being able to physically examine patients and so forth. So I think there's a lot of uncertainty there. But that reimbursement, if there isn't adequate reimbursement, it will disincentivize people from offering the service, which I think can be really impactful and important for our patients. This was from the Pew Charitable Trust Research Center, looking at access to home broadband as well as to a smartphone. And so without having broadband, but an internet-capable device. So as you can see, the rural population, up to a third or even more, don't have access to broadband, and only 70% have access to a smartphone. The low-income population, only 56% with home broadband, and again, about that 71% number with some type of internet-capable phone that would allow for an audio-visual evaluation through telehealth. So this is itself a social determinant of health, not just for addiction care. And I think we can agree that the addiction community, there is a subset of that community that is really going to have minimal resources and unlikely to have home security, let alone broadband, or works from temporary phones that may not even have barely have texting capability, let alone internet access capability or FaceTime type capacity. So that population is going to be vulnerable, but that's true of low income and rural populations or urban populations, particularly urban low income populations, for a variety of healthcare needs. And as more care is going to be delivered through telehealth, I think that's inevitable. As Seema Verma from CMS said, the genie's out of the bottle on this. It's going to be part of the future of healthcare to some degree. And those patients are going to have a further division driven between those who have access and those who don't. So another sort of social determinant of health that's going to be important moving forward, that our government will have to address to make sure that people have that access to the internet. But certainly for the SUD and mental health disorder population, this is going to be a significant barrier. So now during COVID, how has that changed? What have we been able to do about it? So there's been a variety of waivers that have been passed. This only is a partial representation. When we're talking to DEA in April, I think, and there are like 31 separate waivers and regulatory changes or temporary discontinuations and all those things as part of the public health emergency, which was declared in January. And honestly, I think sometimes the relationship with like DEA and other agencies can be a little bit tense as we have different experiences and sometimes different goals. I have to say, I think they've responded appropriately to the public health emergency and allowed for services that really go a long way to meeting people where they are. And specifically what they've done is they have suspended the Ryan hate law, more or less for the duration of public health emergency, so that you can use telemedicine to prescribe controlled substances to patients without having that initial in-person evaluation. So a patient who is ready to start on medication therapy, for instance, or needs treatment for withdrawal, they can have that access through telemedicine without having to go anywhere specifically. And they went even further and allowed for telephone only, understanding that with that digital divide, there'd be patients who still couldn't do it or would be forced to then potentially be at higher risk to go to an emergency department or an office setting. And so they permitted telephone only evaluation for buprenorphine prescribing. Technically, that's not available for any other controlled substance. That was specific for buprenorphine. Interstate practice with DEA licenses, so allowing a practitioner in Pennsylvania to prescribe to a practitioner or to a patient in Idaho for whatever reason, or over the border in West Virginia, again to limit how much people had to travel back and forth. In our state, they expanded take-home doses for OTPs from 14 to 28 days, allowed for behavioral health counseling through telehealth, including phone if needed. In Pennsylvania, we have very strict privacy laws for mental health and substance use disorder treatment that are even more strict than the federal guidelines, which are even more strict than essentially basic HIPAA. So they suspended some of those really more onerous portions of it to allow for emergency care, which certainly initiation of substance use disorder care, overdose treatment, withdrawal treatment falls under that category. So it improved our ability to share information with acute care providers for the best interest of the patient, which has been very helpful. So looking ahead, we're practicing under these waivers now, but then what's going to happen moving forward? So we know that right now, unfortunately, we're in a very dark period of the COVID-19 pandemic with hospitalizations, cases, daily death rates, all of those things at all-time highs, and more mitigation efforts being implemented by governors and counties throughout the country. They look different, but the same effect of isolation, people in cold weather, staying indoors, not even having the outdoor activity sort of relief valve. So I think that these kinds of services where we try to connect directly to patients are going to be more important in the next few months than ever before. But hopefully by the time we're into late spring and summer, from what we're hearing, we may be to a point where many of those mitigation factors can start to be lightened significantly as more of the population receives immunizations. But there was a pre-existing need for improved access to care. So how will some of these waivers and temporary regulatory pauses that were implemented during the pandemic, how are those going to move forward after the pandemic? Are they helping people, and to what extent? And if so, what can we do to make sure that they remain in place? While if there are others that maybe didn't help people or were associated with worse outcomes, we make sure that we adjust those or regulate those in an appropriate way. So those are all going to be really important questions. We'll continue to innovate. I mean, just trying to live, working in a telehealth space and trying to stay on top of all of the new innovation and platforms and mobile applications and websites and all of these things that are being developed, it's almost impossible to do. It's almost a full-time job, which is great. But of course, we have to sift through and find the ones that are evidence-based and provide the best care and are most sort of ethically responsible, et cetera, which I think many are, but we just have to be sure of it. Anytime we do something quickly, we really want to make certain we understand what we're doing. So we continue to assess that, working with a group nationwide, and we're collecting data about the patients we're seeing through our various telehealth programs to see how well it's working. And I think publishing that data is going to be really important. And I'll talk more about that in a minute. And then advocating for the ongoing, whether it's waiver or new regulation or new legislation that removes some of these barriers to telehealth services, delivered in an appropriate way that follows best practices, and that's always the caveat. And then reimbursement parity, as I talked about, is going to be really important to make sure that the providers who provide the best care are incentivized to do it in this way. I fear that if there's a low reimbursement, then providers who are already busy and providing good care would be less incentivized, whereas others who maybe are less interested in providing good, well-rounded, holistic care may provide less efficacious care and potentially to the detriment of patients, and that can mean a lot of different things. And then expanded broadband and technology investment. Those things are really important. This I thought was an interesting, this is technically dated for January of 2021, so it's available online from the Journal of Substance Abuse Treatment. And this looks at a number of interventions that are not medication-based, contingency management, episodic future thinking, substance-free activity sessions, and looking at them through the lens of COVID, as well as economics. And I think those are both really important ways of looking at it as we move forward in trying to make the argument about what should be permitted, what should be reimbursed, et cetera. And these things are behavioral interventions, as we know, that can really support not just opioid use, but nicotine, alcohol use, and try to find ways to help patients while they're at home and more anxious and stressed, and maybe at the same time also kind of bored with more free time, which in some cases can make it more difficult to maintain abstinence. And we're seeing a lot of relapses to substance use kind of for that reason. All the things that people did to keep busy and active, sort of at home, just kind of with not a lot of other things to do, and it's easier to move back into those kinds of behaviors. I see that and hear that from many of my patients. So these are other kinds of things that we should be looking at and considering, again, based on evidence that's published, and how do we transition these to services that can be delivered outside of traditional group therapy or in-person therapy venues. And so I think it really, there's just the sky is the limit, but much work needs to be done to establish the benefits and potential harms for these kinds of interventions. So I'm going to share, I just spent the last few days pouring through hundreds of pages of both enacted and proposed legislation as they relate to substance use disorder care, telehealth, buprenorphine access, et cetera. So this act, and actually I have to admit that Dr. Raul Ruiz, who is a congressman from California, and I were residents together in emergency medicine residency here at Pitt back, decade and a half ago. But he introduced this bill, which essentially would allow for the distribution of up to 3 days of Schedule 3, 4, or 5 medications for the treatment of withdrawal or even treatment initiation for opioid use disorder. And really what that means is in emergency departments or other acute care settings, it would allow for take-home doses. So I could give you a 3-day starter pack instead of what now, or historically, the 3-day rule had been that patients would have to come back to an acute care setting like an emergency department each of those 3 days to receive their dose of medication. So it's more travel, it's more transportation issues, it's more barriers, easier not to come back, more co-pays, more cost to the healthcare system, all of those things. So this goes back to some of our conversations from years ago And so finally, that was included in the continuing resolution. So some of you are probably aware, last week the government was going to shut down, so they had a week-long continuing resolution to make sure that didn't happen. But as they do at the end of the year, they start putting in other language into that larger bill. And so the third bullet here essentially is that EVMAT Act. So it allows a practitioner to dispense up to a 3-day supply of narcotic drugs for maintenance or detoxification treatment or both. And so this has been signed into law. So this is it has instructed the DEA to come up with regulations to allow that. I think that's very exciting as an emergency physician who spent a large portion of the last 4 or 5 years of my practice trying to increase and enhance buprenorphine induction in the emergency department. This has been sort of a holy grail for us as something that would really help if I could get this so that either I had all my providers X-waivered or they didn't have to be X-waivered to give people medications to go, which would enhance their likelihood of following up with subsequent care. And so this is going to, I think, be very practice changing once the DEA finally revises those regulations. And I still have to see the final bill language, but that's very exciting. A couple of other laws that I suspect many of you have been following: the Mainstreaming Addiction Treatment Act. This is the Senate version, though the House version reads fairly similarly. The Senate version, I think, is a bit more language on education programs. But essentially, this removed the need to have an X-waiver. So a DEA licensed provider could prescribe a Schedule 3, 4, or 5 drug, such as buprenorphine, for maintenance or detoxification or other purposes. So what this would mean is that anybody who has a DEA license would be able to prescribe buprenorphine. And so I think that this opens up a lot of possibilities for primary care groups and others who have historically not gotten their X waiver or had some of those disincentives, just taking away one more barrier. And that's not to say that everybody should be prescribing buprenorphine if they don't understand it, or that it should be done outside of coordination with larger substance use disorder treatment and care, behavioral health therapy, medical addiction experts, et cetera. But it does take away a significant barrier. So a primary care doctor, for instance, who felt more and more comfortable or who had access to interprofessional or telehealth consultation with a more experienced addiction provider could themselves prescribe this medication or do it on a short term, or emergency department physicians could prescribe buprenorphine for 5 or 7 days to get folks into treatment. And so I think if this event eventually were to pass, it would be a game changer. The TREATS Act was introduced earlier this year, looking to expand, essentially take those telehealth waivers that I described before from the public health emergency and put them into law. It did not go very far on the telephone only, outside of, I think, Medicaid, but did allow for essentially addiction treatment that did not require adherence to the Ryan-Haight limitations. So that was introduced in June, and I and others have been advocating on it and also trying to add the telephone portion of it, as that's been a really big part of our practice that's been very successful. And so right now there's a huge bill. It's 525 pages that's being worked on, as I'm sure many of you who are watching the news, for COVID by bipartisan Senate and House leaders. And obviously the primary goal is to fund COVID-related relief and vaccine distribution and small businesses and payday loans and preventing evictions, all those really important things. But included within that, as you can see here, are Section 2004, and this would extend those telehealth waivers. And essentially what this would do would be allow the Secretary of Health and Human Services to continue those waivers through the end of 2021, regardless of when the public health emergency ends. And so I suspect incoming Secretary of Health and Human Services, Becerra, would likely take advantage of that. Of course, we would need for those waivers to be extended, assuming that the public health emergency ends before the end of December next year. If it doesn't, then the public health emergency continues through, then those waivers will continue. And the law says whichever happens later, essentially. And the other thing here is Section 2103, which expands access to medically assisted treatment. Essentially, that is that Mainstreaming Addiction Treatment Act law, but in here. So that would permanently remove the need for an X waiver if this passes in its current form. And there's other, as you can see, the next section describing significant funding to a variety of substance use disorder programs, states for use for SUD treatment programs, and not specific to opioids, which has been something we've been talking to Congress a lot about, is that we need to cover alcohol, stimulants, other things, as well as opioids. And they did expand that language in this bill. So I'm nearly done. I just want to talk about a couple of our programs that we've developed as examples of how we've taken advantage of the telehealth services. So all of our emergency departments now at UPMC, and so as I said, that's a couple of dozen. My toxicology group, provide 24/7 telemedicine consultation services. So we can help them with induction if providers are uncertain as to when, how, not when it caused precipitated withdrawal, et cetera, as well as e-prescribing of buprenorphine through our electronic health record. And so all of our hospital EDs have equipment that was originally placed for telehealth evaluations. And so we use that same equipment to do telehealth evaluations. And that's been very successful so far, both with patient provider satisfaction as well as follow-up engagement rates. During the pandemic, we've actually developed a telehealth bridge clinic, and this is our toxicology group anywhere in Pennsylvania, and we can do direct-to-patient treatment. So what we have asked is that, and I'll show you a flow, is that this runs through local care management groups or providers. So whether it's a single county authority who are county drug and alcohol commissions, or a treatment provider who engages a patient but is unable to get them into the medical therapy, for instance, buprenorphine or alcohol withdrawal management quickly, rather than going to an emergency department, they can call us and schedule an appointment the same day or the next business day in our bridge clinic. And we'll see them either through audiovisual or audio only and provide the appropriate prescriptions, while the local case management continues to facilitate their behavioral therapy, getting into subsequent medical therapy, things that then become a bit less urgent for the patient once the medication and withdrawal treatment is initiated. And then I'm also the medical director of the Pittsburgh Poison Center. And so we've developed what we call Bup on Call. Essentially what that is healthcare providers or lay people can call the Poison Center with specific questions about buprenorphine or other MOUD induction processes. We have methadone algorithms as well as buprenorphine for hospitalized patients, emergency departments, primary care. We do follow up with those patients. We connect them directly to local warm handoff or engagement services. We don't provide that service, but we connect them while they're on the phone with us. And then we'll follow up with the patient the following day and later in the week to make sure that they're engaged, answer any questions, assess any adverse events, and those sorts. So I think another example of how we can use non-traditional care to augment existing care services. So this is a flow chart for our bridge clinic. And one of the things I've emphasized all along is that we aren't looking to replace in-person care. We're simply trying to add another resource when in-person care isn't immediately available. So if a patient requires medical therapy and they're able to get it locally, with an addiction provider or someone else who is appropriate, then by all means, that's what they should do, because I believe strongly that in-person care and creating that therapeutic alliance with a provider who's going to provide longitudinal care is most ideal and critical. But I also know that there are many times, particularly during the pandemic, but even before that, that while they may get set up with a social worker and case manager and start to have those issues resolved, and even with a therapist or a peer recovery specialist, that seeing the physician who's able to start that medication treatment, which we know the earlier it started, the less likely we are to lose them to follow-up, that can be difficult. And so we wanted to add an option for providers to do that. And so we've had good success. The very first patient I had was for alcohol withdrawal, and then we transitioned to maintenance therapy. He was most interested in disulfiram once offered all the options. We've treated with buprenorphine. I've done oxycodone tapers for people who are just abruptly cut off after more than a decade of pain management so that they could come off smoothly. In a patient who did not have an opioid use disorder, so did not need to go on to Suboxone. They just needed to safely come off their opioids. We've treated, as I said, alcohol withdrawal, alcohol maintenance, buprenorphine maintenance, and our follow-up rate has been really good because we are working with local case management who helps get those folks into treatment and we keep them out of the ED. This is the poison center line I talked about. I don't need to belabor that. And this is some data from our internal medicine addiction providers, colleagues at my institution. So you can see the purple are their, they were only doing face-to-face visits until March. And then that orange was their telehealth visit. So you can see their overall visit numbers actually went up quite a bit, almost doubled, not quite, in April. And I can tell you that there were more patients, not just more visits. So they had more frequent visits, which is something that telehealth allows. Even if they're shorter, they allow you to check in more often because the patient doesn't have to figure out bus fare, childcare, so much time off work, all the other factors that make it difficult to get in to see us. And it also engaged patients who might otherwise not have come, as they saw more patients than they had traditionally. The reason the June number is so low is this data was pulled early in June. So I just didn't have all of June. And this is just again showing that the number of patients went up from 195 to 234 in April compared to March. And the numbers had been fairly steady prior to that, showing an increase not just in the number of visits, but the number of patients. So it can certainly work. There are issues regarding drug screens and therapeutic alliance, and there's a lot of face-to-face benefit that can be had. So I think long-term, short-term, we've had to use this as a substitute out of necessity. Long-term, I think telehealth offers us the ability to augment in-person services with early access and frequent access and urgent access that patients may not otherwise have had. Another time I could think of is if a patient has been in recovery, but is having, an emergency or a crisis where they feel they need urgent help or evaluation, or even just to speak with a peer. I think doing through telehealth will be a great option moving forward. So with that, I'm just over an hour. I apologize for that. I meant to keep it to an hour, but I am happy to take any questions.
Thank you so much, Dr. Lynch. And we did have quite a few questions come in throughout the presentation. So the first one was actually right after you presented the data, and a participant was wondering, are there correlations with other medications for mental health, specifically non-narcotic scheduled drugs such as antidepressants or some sleeping medications in regards to COVID and the higher rates of death?
Yeah, unfortunately, we don't have great death data finalized like that from medical examiners that really digs down deep into the categories of medications associated with it. I suppose my suspicion is that all of those categories will likely rise, both because patients may be prescribed longer durations of medications. That's something that is frequent for us to do in the pandemic now to decrease the rate of visits, so we may give a longer medication supply the patients who might otherwise not have access to. And then again, because we know that mental health disorders, depression, anxiety, and suicidal thoughts have all risen, and patients often will have access to those kinds of medications, that those are likely to rise as well, unfortunately, whether related to deaths or overdose survivals with those classes of meds. And as far as prescribing through telehealth, there's some data through the psychiatry data about prescribing those medications through telehealth, and that there can be good outcomes. So that, unfortunately, I don't have a better answer for you than that. Even for our overdose data, we presume much of it is fentanyl heroin, but we don't have that breakdown in a really scientifically valid way yet on the toxicology.
Thank you. Could you speak a little more about the success of telehealth as it relates to those in areas of poverty or maybe below poverty?
Yeah, well, I'd love to. I would love to know more about it. I think that I'm not aware, I shouldn't say we don't have, I'm not aware of good data on the demographics of patients who benefit from telehealth. I think the expectation and the assumption is that it can offer a way to connect to patients that have historically been disenfranchised from the healthcare system, both through ease and convenience and things like that. We know that demographic is more likely to go to emergency departments, for instance, to receive care that isn't necessarily emergent, either because they aren't aware of local primary or outpatient care, or they don't feel comfortable with it, or don't feel, sort of empowered to access it. So I think that there is a huge potential to be able to meet people where they are and be more comfortable in their home setting, as well as the other barriers of travel, transportation costs, et cetera. But the digital divide and barrier is really a significant issue that I've run into quite a bit, where a lot of my visits have been phone only because I haven't been able, because the individual is unable to access internet or an iPhone or a cell phone, smartphone. And so I've had good success, and patients have been really receptive and appreciative, and sort of in awe that was even an option for them. And I know, because they're engaged with others, that they then have follow-up. Of course, that always runs the risk, if it's not set up with some sort of local treatment, phone only in isolation kind of interaction, I think raises some concerns long-term about the effectiveness and the motivation, engagement, and diversion, and all those kinds of things that can become an issue. But I think that the lower socioeconomic demographic could stand to gain significantly, particularly if we can do things like establish pods or other access points that are private, that patients can seek telehealth care, in a community center or grocery store or pharmacy or library or whatever is in the community that they may feel more comfortable with or have greater access to. I think that is a way of amplifying and stretching the services into communities where they may be most needed and least accessible. And I'm sorry, I have more data on demographics.
Our next question is kind of linked to that one. It is about the telehealth, and this question is there any research about success of telehealth in relationship to gender or ethnicity?
So you all are asking fantastic questions. I will be perfectly honest. I'm sure there is some research along those lines specifically. I don't know that I don't have at my fingertips the answer to your question. So I'm certain there is some research. I can tell you that in general, particularly pre-pandemic, telehealth research was still relatively rudimentary in a lot of fields. Some areas like psychiatry, stroke, and things like that had a more well-developed evidence sort of catalog than almost anything else. So those types of subgroup analyses that are so important to how we target care and education and outreach and so forth are limited, are minimal. I can't say that they aren't there because I'm sure that they are, but not largely, not in a lot of the summary data. So any studies that look at it are probably smaller. And to be perfectly honest, I don't know. In the substance use disorder research that I've looked at more specifically, as well as the larger analyses, meta-analyses, et cetera, reviews of telehealth data, that has not been a commonly studied sort of analysis, at least not prospectively. But I think that that's a really great point, and an area that I'm sure somebody could make an entire career and should out of doing.
Okay.
And I don't mind sending slides. Answer the final question.
Yeah, there weren't any other questions that came through. I did want to there were a couple of comments about the slides, and so as long as you're okay, Dr. Lynch, with sending them over, we can post a PDF version of the slides along with the webinar recording for today's presentation, have them held as a resource on our website in our webinar library. And that really, that was the only other comments that came in about the slides and stuff. So with that, I'm going to say thank you, first of all, to Dr. Lynch for such a good webinar. And thank you for everybody participating and sending your questions in. If you have any questions after the fact, you can feel free to email us at info@ireta.org, and we can be sure to get those questions over to Dr. Lynch and get you some information back. I do just want to remind everybody again that we are sending out a couple emails after our presentation concludes today to remind you about participating in our evaluation survey and also information on how to access certificates of completion and CEUs. Please note that it can take up to 48 hours for your certificates to become available because our systems cross-check one another and have to verify attendance records. Again, I just want to thank everybody for taking time out of their day to participate and join today's webinar. And again, any questions, please feel free to email at info@ireta.org. With that, I'm going to conclude today's webinar. So thank you again so much, Dr. Lynch. We really appreciate it.
Of course, I was happy to.
Thanks, everybody. Bye-bye.